Direct medial, approach for midfoot, collapse for bony. Planing and skin. Ulcer treatment. This video was produced from a book source. We would like to thank the editors Debord Piet, Richard Buckley, and Stanley Hoppenfeld. Citation: Debord Piet, Richard Buckley, and Stanley Hoppenfeld. Surgical exposures in foot-ankle surgery, the anatomic approach. Lippincott Williams Wilkins, 2012. This approach is used to treat patients with severe foot deformity associated with diabetes, or in patients with midfoot collapse due to a Charcot-type neuropathy. A bony prominence through the plantar surface in patients with neurological sensory deficits often results in severe skin ulcerations over the plantar surface. Without removing the prominence, skin ulceration will continue. Techniques may be necessary before surgery to optimize local soft tissue conditions. A detailed neurological and vascular examination is mandatory. Specialist investigations such as angiography may also be indicated in specific cases. Supine on the operating table. The dorsomedial approach and the longer complete medial approach are carried out with the leg in its natural position of slight external rotation. If necessary, a sandbag may be placed beneath the opposite buttock to create even more external rotation of the affected limb, making the medial aspect of the forefoot more easily accessible. After exsanguination, apply a tourniquet to the middle of the thigh. Do not use a tourniquet applied just above the ankle, as this may create vascular problems post-operatively in diabetic patients. Landmarks and incision. Because this incision is used to treat midfoot collapse and foot deformity, the normal bony landmarks will be distorted. Palpate the medial malleolus as the bulbous end of the distal tibia. It can nearly always be palpated proximally and is a reliable bony landmark. Distally palpate the first metatarsal, which is easily felt on the dorsal aspect of the midfoot. Finally, palpate the bony prominence of the collapsed midfoot overlying the ulcer. Make a 4 to 6 cm longitudinal incision directly over the area to be exposed. The plantar medial incision lies directly over the bony prominence to be removed. The approach usually runs from the base of the first metatarsal over the navicular. Internervous plane. No internervous plane is available for this approach. The muscles whose tendons are exposed receive their nerve supply well proximal to the approach and are therefore not denervated by the approach. Superficial and deep surgical dissection. Cut down directly onto the bony prominence to be planed. Figure. Preserve any cutaneous nerves that can be identified. Ensure that skin flaps are full thickness to minimize the risk of skin necrosis. The structures over the plantar medial surface of the foot are prominent if the skin changes are on the plantar surface. The extensive insertion of the tibialis posterior onto the tuberosity of the navicular, the inferior surface of the medial cuneiform, and the bases of the second, third, and fourth metatarsals will be visualized. Great care should be taken to preserve these structures. How to enlarge the approach. This approach can be extended both proximally and distally. Such extensions are indicated if the local bone excision is to be combined with other surgical procedures such as tendon lengthening, shortening, or transfer. Proximally extend the incision up posterior to the medial malleolus, curving it to a point midway between the medial malleolus and the Achilles. tendon. The incision can also be extended distally, in line with the first metatarsal. Be aware of the need to identify and preserve cutaneous nerves to prevent permanent local foot anesthesia. Thanks for watching. Subscribe.